I'm very pleased with this turnout, guys. I thought there was going to be 5 people here. So I'm very excited to talk to you guys about a topic that I'm very passionate about, vascular surgery. A lot of times people don't even know what we do or what we treat. And so we're going to kind of go over a very broad overview of what a vascular surgeon does and what we treat. Okay? And we can keep it informal. If you guys have a question, don't feel like you need to save it to the end. If you raise your hand, I'd be happy to try to answer it. This is an overview of what we're going to talk about. We're going to talk about something called PAD, peripheral arterial disease. We're going to talk a little bit about carotid stenosis, which is the artery in your neck that goes to your brain. We're going to talk about aneurysms, specifically those in the abdomen. We're going to talk about some venous disease and then some special considerations. So starting off with PAD, this is a disease of the blood vessels out of the heart, so outside the chest. So generally, when I describe to usually friends and family what I do, I say we operate on the blood vessels, everything that's outside of the chest. And when we talk about peripheral arterial disease, what we're dealing with is blood vessels hardening and narrowing, and the symptoms that are a result of that hardening and narrowing. This commonly will present in the lower extremities, and we call it lower extremity PAD. So if you think about the heart, when you get blockages in the heart and your heart starts to beat harder, what happens is you get chest pain because your muscles aren't getting that blood flow or that oxygen that it needs. The same thing happens in the legs, right? So if you are doing activity and walking and your muscles aren't able to get that extra blood flow, you start to exhibit pain in your legs. And that's actually what we term claudication. So claudication is just a fancy way of saying pain in your legs, usually your calves, when you walk a set distance every time you walk that distance, okay? And that pain typically goes away quickly when you rest. And it's like angina of the legs. So that's the same kind of process that's happening, except for it's happening in the muscles of the leg. That's one of the first signs and symptoms of lower extremity PAD is this claudication. If it progresses further, you can exhibit something called rest pain, which is essentially pain at rest, right? Like you're not walking now to get the pain. Even when you're laying in your bed, you're having that pain. This can then progress to, I have a couple of gross pictures, so I hope nobody gets too grossed out. But that can progress to things like this ulcer on the toe here if it's not addressed. When we see patients in the office, what we see is that their pulses are diminished, they're not as strong as they should be, or even we listen with the machine, and sometimes even the sound with the machine can be different than what it should be. So generally with a lot of the disease processes that I'm talking about, risk factor modification is always the first step. And it's, when we talk about like cardiovascular health or heart health, the same applies to the stuff that I'm talking about, right? So if you have narrowing and hardening of the arteries of your heart, that same process is happening all throughout your body. And so some of the ways that you can mitigate that or slow it down is something as simple as being active, right? Just walking 30 minutes, 5 days a week. That's generally what we'll tell patients as their first line of treatment to see how much we can boost their circulation just on their own. And obviously no smoking. I'm gonna say no smoking 1,000 times during this presentation. So, there's lots of people that we see that aren't smokers that get vascular disease. That's genetic, right? That's not anything that they've done. But if you have that genetic component and then you add the smoking to it, you're gonna accelerate that disease process tremendously. So smoking is a big thing that we see as a kind of social history in a lot of the patients that we have. Medications like statins that lower your cholesterol and things like aspirin and Plavix are common medications that our patients are on. Especially in our diabetic patients, so a lot of times lower extremity PAD is in combination with diabetes. We emphasize good foot care, getting a podiatrist, seeing them on a regular basis, clipping your toenails. For some reason, people don't lotion their feet. Lotion your feet, right? Because if your skin gets cracked, bacteria can get in. That can be an easy way to start infection, cellulitis. So just taking good care of your feet. Don't wear ill-fitting shoes. A lot of times diabetics lose sensation in their feet, and they'll buy a nice pair of sneakers and not know that they're too tight and get a sore that way. People love to soak their feet. I absolutely hate soaking your feet because it's ridden with bacteria. Whether you're doing it at home or you're going and getting a pedicure, it's a surefire way to let bacteria get under your skin. So I don't advise soaking your feet. And then obviously good diabetes control, right? Have good blood sugar levels and see your endocrinologist and all that good stuff. So if someone comes and sees us and we determine they have symptoms that would be typical of something for lower extremity PAD, there's a certain workup that we do in a sequence. And usually the first test we order is a non-invasive test called an ultrasound. Same thing they use on babies. What it'll do, it'll kind of quantify your degree of circulation. So ideally, we'd want the test to come back and say, oh, you have 100% circulation, or it'll come back and say, you have 40% circulation. That's kind of where we start our workup. Once we see by ultrasound that your circulation is abnormal, then we do things like CAT scans or angiograms to get a better idea of the anatomy of what's going on. So one of the first-line treatments for patients that we diagnose with clear-cut PAD is to do endovascular procedures. And what does that mean? It's minimally invasive procedures to improve the circulation where we don't have to make a cut. We essentially go into the blood vessel with an IV, and from inside the blood vessel, we do all the work. This is an example of our suite over at Oracle. We use some local anesthesia to numb the area that we're going to put the IV in. We give you a little bit of sedation so that you're still breathing on your own, but you don't remember or feel a lot of what's happening. And it's a quick procedure. It's like 60 to 90 minutes. We're able oftentimes to treat whatever the underlying cause of the blockage is. You recover for a couple hours at the lab, and then you go home, and the next day you're back to normal activity. Low complication rate, very effective. It's kind of changed the practice of vascular surgery quite a bit. And then these are some of the examples of actual things that we do in the endovascular suite. They can range from what's called PTA, or percutaneous transluminal angioplasty, what most people know as ballooning, where we'll put a wire across the area of blockage and literally blow a balloon up to expand that space. Atherectomy, which is kind of like roto-rootering the inside of the plumbing to clean it out, and then doing either stenting or ballooning after that. And then stenting, what most people know, is to place like a scaffold of wire to kind of prop these blood vessels open. This is a typical example of a patient that we'll see. This guy was a construction worker. So basically, he couldn't do his day-to-day job because he was getting so much pain at short distances when he would walk, and he'd have to walk the site from here to there. And by the time he was at the other side, he had to sit down and rest. And so we call that lifestyle limiting claudication. We brought him into the procedure suite. We did an angiogram, and this is just a typical picture that we see once we get everything in place. We inject dye, which makes the blood vessel light up under X-ray. We shoot an X-ray, and this should be just a solid, thick line. This is the blood vessel that's in your thigh, called your femoral artery. And you can see that there's multiple areas of narrowing throughout the length of that artery. So what we do is we use a wire to cross the area. We use a device that spins and kind of sands down the inner lining, and then after that we balloon it. And this is a very typical result. So had it the same day, was able to go home and return to work the next day with complete resolution of his symptoms. And this is another recent patient, a little bit more severe disease. This patient was 65. He had an ulcer on his first toe that was not healing. So we did that workup, ultrasound, CAT scan. He had a blockage behind the knee, so this is your knee joint right here. And we were able to cross that with a wire and balloon it. Sometimes when we balloon it, it just doesn't look, there's some residual narrowing that's there. And so in this case, we did place a stent, did wonderful, went home the same day, and then within a month, so he had had this wound for 6 months. But once we fixed the circulation, within a month, the toe was healed. Oh, sorry, gross picture. And then there's traditional bypass. You know, this is tried and true. Sometimes we exhaust all the minimally invasive options and there just isn't anything more we can do. And in that case, we do a surgical bypass. What does that mean? We literally take a conduit, so it can either be your own vein or a prosthetic conduit, and we go around the blockage. So we sew it into the artery where it's normal above, and then sew it into an artery that comes back lower down. And this will bypass or go around the area of blockage. It's a big procedure. I usually tell patients, you know, it's not as big as having a heart surgery, but it's definitely not as easy as coming in and getting an endovascular procedure. Long recovery time, lengthy hospital stay, but sometimes that's our only option. Moving on to carotid disease. Y'all probably know the mnemonic for having a stroke. This one's called FAST, talking about the symptoms that you would see that would be concerning for stroke. One of them is facial asymmetry, so drooping of the eye and face or mouth. Weakness in the arm and leg, usually together just on one side, and then your speech being altered. If you do have these symptoms, you want to immediately call 911 and get taken to the emergency room. What I have written there, TIA, it's called a transient ischemic attack. Most people know this as a mini stroke. And all that essentially means is you have stroke symptoms, but they quickly resolve. When you do imaging, you can see the residual damage that's been done, but from a neurologic standpoint, you've recovered completely. So we call those either mini strokes or TIAs. Again, similar to what we talked about for PAD, we always want to try risk factor modification first. Especially with carotid patients, we like for them to be on best medical management. And what that means is dual antiplatelets, which are aspirin and Plavix, in addition to something for cholesterol, which is a statin. That's been proven in our literature for decades now to reduce your risk of stroke once you have a certain degree of narrowing in your carotid artery. Don't smoke, eat a good diet. So unlike PAD, where someone can come to our office and have complaints, right? With carotid stenosis, it's often silent. You don't find out you have carotid stenosis until A, you have a stroke, or B, you're getting worked up for something else and they just incidentally find that you have narrowing in your carotid arteries. So for screening purposes, we generally recommend, like when your primary care doctor does your overall physical, a lot of times they'll listen to your neck with their stethoscope. They're listening for something called a carotid bruit, which is like a change in the sound that happens when there's a narrowing there. So if you do have that physical exam finding, you'll get a screening test. If you have evidence of vascular disease in other parts of your body, a lot of times it's good to get a screening test because, again, if it's happening in your heart, it's probably happening everywhere. So coronary artery disease, peripheral arterial disease, or aortic aneurysms, we recommend those patients get screened. And then if you have greater than 2 just general atherosclerotic risk factors, so atherosclerosis means like narrowing and hardening, those include high blood pressure, cholesterol, if you smoke, or if you had a family history of stroke. Workup very similar as for PAD. We usually start with non-invasive tests again. We'll do an ultrasound of the neck. It's a great test for carotid because it's not a static exam, meaning it's not like you take a snapshot. You're looking at the flow through the vessel itself, which is a very good indicator of the degree of narrowing. Once we have that information, and if it shows that there's substantial narrowing, then we go to things like a CT scan or an MRI to get a better idea of the anatomy of the narrowing. And this is actually one of the patients recently that shows that there was a pretty severe narrowing. You see that white line that's coming up, and then there's a wiggly one coming off. There's a narrowing right there right after the takeoff. So which patients do we decide that we're going to do something on? This is based on the literature. If you're asymptomatic, so you've never had any neurologic symptoms, you've never had a stroke, but your degree of narrowing is over 70, 80%, generally we recommend repair or addressing this because your risk of stroke within the next 5 years is fairly high, okay? In those patients with symptomatic stenosis, meaning they have had a recent stroke, that criteria is brought down because we don't want them to have another stroke. And by having had a stroke, they're indicating to us that that area of narrowing is unstable. So and you're going to see this theme is with vascular surgeries, we always have endovascular options, so minimally invasive, doing it through the inside of the blood vessel, that then progress to more open options. So when I was in my training, we were doing carotid stenting through the groin. We were reserving this option for patients that had really high cardiac risk because the risk of stroke during this procedure was fairly substantial. And the reason being is that you were crossing this area of blockage in order to place a filter. Well, before you place the filter, what's capturing any debris that you might break off? And so that's why there was a pretty substantial risk of stroke for doing it this way. Nowadays, we do what's called TCAR, so transcarotid artery revascularization. We make a small incision at the base of the neck. We hook you up to a flow reversal system that has a filter and then returns clean blood to an IV in your groin. What this affords is protection against stroke while we're doing the procedure. So we get this all set up before we even cross the area of concern. Once flow is reversed, we use a wire to cross, place a stent, expand it, and then remove everything and wake you up. This procedure I generally do it under general anesthesia as opposed to a lot of endovascular procedures, but can be done under some sedation as well. This is a very recent patient that I did who had actually neck surgery back in 2019, was coming just for routine follow-up. And generally, so one of the things I love about vascular patients is like, if you become my patient, we got a long relationship. Like you're gonna see me every year, we gotta get tests every year. So there's a lot of like kind of primary care worked into vascular and that we see each other on a regular basis. So was getting followed up yearly with ultrasounds and was progressively getting more and more re-narrowed. So trying to operate on an area of the body that's already been operated on before can be risky and have a lot of complications to it. So while there is always the option to reoperate, we try to avoid it in this situation. The ultrasound showed a very severe, as you can see in the picture on the left here, a really severe narrowing of the carotid artery. And what we do, again, this was a TCAR patient. We got everything in place. We got flow reversed. We're able to cross the lesion with a wire. That middle picture is a picture of the stent is mounted on a balloon, and we're expanding the balloon and deploying the stent. And then that's the picture on the very right there is after the stent is deployed. This is tried and true surgical endarterectomy is the way we've been doing carotids surgically for decades. We make an incision in the neck, we get down to the artery itself, we clamp it, we open it, we literally scoop out the blockage itself, and then we sew a little patch onto it. So moving on to aneurysms, so abdominal aortic aneurysms, the big blood vessel that runs down your back, takes your blood flow to all the organs in your body. It can weaken over time in certain patients, usually because of genetic reasons, and it gets larger than normal. When it gets larger than normal, the strength of the wall is compromised and you run the risk of rupture. Signs and symptoms. So this is like carotid disease. There's generally no symptoms, right? Like patients will be getting a workup for a UTI and incidentally find that they have an aortic aneurysm. That's what we love to see because then we can follow them over time and do something about it before it becomes a problem. If you have pain, it usually means that you've ruptured. That's very dangerous. You need to go to the hospital immediately. It generally presents as very, very severe back pain that does not get better at all, okay? That's why we love screening. Generally, when you do your welcome to Medicare kind of thing, if you're over the age of 65 and you have a smoking history or any cardiovascular risk factors, or a first-degree relative with a history of abdominal aneurysms, you would qualify for a screening ultrasound, which again is an easy test. Just make sure you don't eat anything so there's no gas and they can really do some measurements. But it's an excellent screening test to just get the size of the aorta itself. The workup, again, aortic ultrasound. If this shows any abnormality, we follow it every year with another ultrasound. Once it reaches like 4.5, 5 centimeters, then we recommend it more frequently. So maybe instead of every year, we'll do every 6 months. Once it reaches 5, I usually get a CAT scan to get a better idea of what the anatomy is. And once it's over 5.5, that's when we recommend repair because your risk of rupture really increases at that size. So endovascular aneurysm repair, we call it EVAR for short. We put 2 IVs in the groin, and then from inside the blood vessel, we reline the aorta and the iliacs, which are the 2 blood vessels that go to the leg, with a covered stent graft to redirect the blood flow into the tube that we're placing and not into the aneurysm itself. What does that do? It decompresses it so that it no longer carries that risk of rupture anymore. A lot of patients will say, well, aren't you going to take it out? And you say, no, we're not going to take it out, but what we're doing is we're taking away the risk of it being there in that it's not going to be pressurized anymore. This was an 88-year-old male who presented with very severe back pain, was not getting better, had a history of coronary artery disease, had had a bypass in the past. Well, we got a quick CAT scan in the ER that showed a very large aneurysm. So your aorta normally is probably like maybe 1.5 centimeters, right? That's normal size, so about like that. So 8.5 is very, very large. And this picture right here, you can see that white tube and then it looks like a big bulbous, that's the aneurysm itself right there. So, 20 years ago, if you came to the ER with that, you probably had an 80% chance, because he had ruptured. If you came to the ER with that CAT scan, you had an 80% mortality. That's horrible. Now with EVAR, you repair it in, it's very easy. Patients recover very quickly. He was transferred to the ICU for 1 day and went home on the 2nd day. As opposed to what I'm going to talk about next, and this is another gross picture, which is open repair. To do an open repair, you have to get an incision all the way from your sternum to your pubis. We have to go all the way down to the aorta, which lies right on top of your spine. And then we open the aneurysm sac and we sew a graft, and that's what you're seeing here is the graft sewn into place to replace the aorta that we've opened. This is a fantastic procedure. There are some patients that don't have the anatomy for an EVAR, but it does, again, like the open bypass for PAD, it requires a lengthy recovery, a lengthy hospital stay. It takes a toll on your system. This might be the last thing that I'm talking about, which is venous reflux. Very, very common. Generally not anything dangerous, but something that a lot of people have symptoms from. What does it mean? Your body has valves inside the veins that make sure that blood is slowly pumped back to your heart, especially when you're standing or sitting. What happens in venous reflux is those valves start to get inefficient or leaky, and when you're sitting or standing, instead of blood going up towards the heart, it's actually pooling downward and creating pressure. That pressure then gets transmitted to the skin surface veins. You can see things like varicosity, spider veins. Legs can feel very heavy, especially at the end of the night, swelling. And if this progresses over many, many years, it can even lead to ulcerations that we call venous ulcers. Again, risk factor modification is always kind of where we go to first. We ask that all patients do a stocking trial, compression stocking, usually about 3 months. It's for two reasons. One of them is for insurance purposes. The other reason is that it's a good litmus test to see if it is indeed venous reflux that's causing your symptoms. Because when you wear compression on a consistent basis, and what I mean is put them on first thing in the morning, wear them all throughout the day, take them off before you go to bed. What you're doing is you're providing some external support and relieving some of the reflux that's happening throughout the day, which should relieve some of the symptoms. And then we highly recommend weight loss, sometimes especially in the setting of leg swelling. That can be more related to something called lymphedema, which is more related to weight than venous reflux itself. So we like to kind of tease that out. The treatment of venous reflux, if symptomatic, is what's called endovenous ablation. There's different modalities that we can do this with, but again, it's something that we do in our procedural suite. It just requires some local anesthesia. It's very quick, with a minimal recovery time, low complication rate, very effective. Essentially what we do is we place an IV in the refluxing vein low down in the leg, and then from inside the vein we thread a catheter that has a tip that either has heat or laser, and then we numb the bed that the vein sits in, and we slowly withdraw the catheter as we apply energy, and what it does is it seals that dysfunctional vein shut. Most patients ask at that time, well, what happens to your blood flow? Like, how does it get back up to your heart? Remember that this vein isn't working properly to begin with. Your deep system of veins is taking blood flow up like it's supposed to, and you're essentially just eliminating an additional source of backwards flow that the deep system is having to deal with. This young lady was a nurse. She was very young. She did her 3-month trial of compression. She got some relief from wearing compression, but it wasn't enough to be able to let her do what she wanted to do day to day. Her ultrasound showed that she had what we call great saphenous vein, which is your main vein that runs from your groin to your ankle. She had reflux in that vein. This is actually her before and after. You can see she had very large varicosities kind of on the outside of her leg. And then this was probably a couple months after we did her treatment. They all decompressed because that source of pressurization and backwards flow had been treated. Again, this is Dr. Abdullah doing a procedure there in our suite. We use an ultrasound to get into that vein. Again, from inside the vein, we thread a catheter. The tip is used to seal the vein shut. And even greater option now is something called VenaSeal, where we give aliquots of glue along the path of the vein that we're treating. And the reason why it's great is that you don't have to infuse a bunch of numbing medication, so your recovery is essentially nothing. Like, I've had patients go to work the same day as they get the VenaSeal because essentially there's no inflammatory reaction from anything that we do. And this is all the interventionalists at Oracle. This is our suite. We've been open for a little over a year now with the suite. And again, we can do a vast majority of the endovascular procedures, whether it's arterial or venous there. Awesome staff. I feel very blessed to be able to join the group. And this is my this is my biggest accomplishment. These are my twins. They're 8. I made them. I appreciate all of you being here and giving me your attention. Thank you.